Good afternoon, everyone. I want to thank Grzegorz and Jan for the opportunity to present my topic and case, treatment of type 1A endoleak using laser fenestration of an endograft to the LSA. Type 1A endoleak is a sealing failure at the proximal stent graft's attachment to the vessel wall. Sizing guidelines for avoiding type 1 endoleak in aortic arch proximal seals. Greater than 25 millimeters in long, less than 38 millimeters in diameter, less than 15% oversizing. Avoid acute angles for proximal seals. Risk of covering the LSA, stroke, spinal ischemia, left upper limb ischemia. Coverage of the LSA only needs 10 to 15% revascularization, Professor Chiesa. Revascularization techniques for the LSA. Transposition of LSA and LCCA bypass, endovascular techniques with antegrade flux during TIVAR, custom-made fenestrated or branched stent graft, scalloped stent graft, also parallel techniques, chimney, periscope sandwich, PMSG, like homemade fenestration in situ, mechanical, radiofrequency, laser. Also, off-the-shelf, single or double branched stent graft, scalloped stent graft, and Cook medical devices, fenestrated, scalloped stent graft, branched stent graft, and inner branched stent graft. We have also Gore thoracic branch endoprothesis, Medtronic Mona LSA, and relay branch stent graft. Chimney stent may potentially displace the aortic stent graft and can induce a type 1A endoleak. Chimney is preferred over fenestration in situ if the opening of the LSA is an acute angle less than 30 degrees, type 3 arch. Risk of failure fenestration in situ. Difficulty of fenestration in situ depends on the type of aortic arch. Fenestration in situ is not recommended if the angle of the LSA is acute, less than 30 degrees, type 3 arch. Fenestration in situ, we have the mechanical with needle or stiff guide wire, thermal, radiofrequency, and laser. Little history. In 2004, McWilliams performed the first of use retrograde fenestration in situ to LSA using stiff guide wire. 3 years later, Professor Panetton from the United States first created laser fenestration for LSA. In the department of Professor Lagrange, we did a laser procedure at the renal visceral arteries level in September 2016. And now we have 62 cases. We used image fusion for this procedure. This slide shows a list of material, and now I would like to present 7 stages of the laser-made procedure. Under image fusion, we put in stent graft at the level of target arteries. Catheterization through the left brachial artery, positioning tour guide. Laser arteriectomy catheter spectranetics was used for the stent graft perforation. Predilation with cutting balloon, second predilation with another balloon, and stenting with V12 and flaring with another balloon. Case report: 68-year-old female patient, increase in proximal thoracic aneurysm to 60 millimeters in diameter with diagnosis type 1 endoleak. Comorbidity: in April 2015, thoracic stent graft for thoracic aneurysm. In June 2015, Cook branched stent graft. Our decision: laser fenestration of endograft to the LSA. Cause of type 1 endoleak: the upper neck was very short and irregularly shaped. Here the slide which shows this endoleak. And we did the sizing, precise sizing with ounce diameters and choose the stent graft. Our procedure: 2 valiant stent grafts were deployed just below the brachiocephalic trunk. During the first phase of the laser-made procedure, catheterization took place through the left brachial artery. Next, laser fenestration of the stent graft. A V12 stent was deployed to the LSA. Finally, intraoperative angiogram showed complete disappearance of the type 1 endoleak and patency of the stent to the LSA. Post-operative CT scan showed disappearance of the type 1A endoleak and patency of the stent to the LSA. This slide shows the stent graft and stent to the LSA. In conclusion, laser-made technique seems to be effective, reproducible, and relatively inexpensive. It's a quicker option with no need for customized endograft, which safely allows revascularization of the LSA during treatment of type 1 endoleak following TIVR. Advantage of laser-made versus custom-made stent grafts: immediately available, sizing is easier, simpler to do, less expensive. And I want to let you know about the 8th International Krakow Vascular Summit on the 10th and 11th of December this year, organized by Professor Wacław Kuczmik and Professor Piotr Kasprzak, where there will be a session of 6 Polish foreigner vascular specialists organized by myself. Thank you very much for your attention.